Thank you, Vikasji, for letting me be over here. Vikasji, you know, it takes a lot of effort on my part to wake up in the morning at 6:30. Thank you for permitting me to do that. Chairperson, Dr. Pasi, Dr. Sudeva, sir. So when we look at the old Medical Council of India regulations, we look at the new National Medical Commission regulations, one thing comes out at the end of the day. That is, we don't care how hard a student tried. We don't care how close he got to. But until she can perform, he must not be certified as being able to perform. Am I right, Dr. Mohan? You know, as an examiner, all of us have gone, Dr. Sadeva, Dr. Pasi and me, I think we probably roamed the whole of the country around. And at times, I put my hand on my heart and say, I have passed so many students who may not have deserved. So what I did was, on the India map, I started putting red dots. That this is a place where I went and I passed an MS candidate who did not deserve to pass. Unfortunately, at the end of 42 years of my career in ENT, half the country is red. So that just shows, was I a good examiner, was I a bad examiner? It depends on who looks at it. A bad student will look at, I'm a very good examiner. A good student will look at it that I'm a very bad examiner. But having said that, I come to what is our problem. Our problem is very simple. At this young age, this baby has taught what my problem is. I care 2 hoots for anybody. Problem is what? Problem is physicians of tomorrow, that is our students, are taught and evaluated by teachers of today, that is quite a few of our faculty members, using methods and skills of yesterday. What I was taught, that is it. I will not change my mind. It is my way or the highway. If you do not tell me that this thing, tonsillectomy, needs to be done by the guillotine method, I will not pass you. But where was guillotine method? So I look at it this way. When I was doing my MS ENT, PGI Chandigarh, 1981, 82, 83, that time, paper 4, recent advances of ENT. But what I learned in recent advances at that time, today I teach in history of medicine. Unfortunately, by the time these residents are there, who would be learning recent advances, in the next 10 years, they are going to come into the history of medicine. Your kids are going to learn recent advances and turn them into history of medicine in 5 years. That is how fast science is progressing. Why? I'll just give a small quotation. किसी ने वक्त से पूछा कि तुम हर समय भागते क्यों रहते हो? Somebody asked time, why do you keep on running all the time? वक्त ने कहा, मेरा काम है दौड़ना. The time said, my job is to run. अगर तुम मेरे साथ नहीं भागोगे, नहीं चलोगे, तो तुम पीछे रह जाओगे. If you don't walk with me, you will stay behind. That is what time is all about. So what is the issue again? We have 6 million physicians worldwide, 7.7 billion inhabitants worldwide, 1.37 of them stay in my country, 4,300 medical schools across the globe, 731 medical colleges across the country. This is as of yesterday's statistics. 1,12,400 undergraduate students passing out each year, 68,000 postgraduates across DNB, MS, etc. And this is what we are looking at. So if my 68,000 postgraduate students are joining each year, I have to write 68,000 theses every year. From where am I going to get the topics ethically? Am I going to copy-paste? Am I going to do research? It's a matter of debate. So what happens? Over the last so many years, did our curriculum change? No, probably. What long case, short case, instrument, viva, what Mohan's dad appeared in his fellowship in UK, he probably was the same thing, and today our residents are also learning the same thing. The contents have also remained the same, CSOM unsafe, laryngectomy, etc., etc., etc. So the question that came across was, do we need a reform in our system? Yes, but were any attempts made? No. Why? Because the powers that be were people like me, who did not want to change with the time and thought that what I know is the best and therefore it should not change. The other day I was going through the list of equipments which are mandatory to be taken in every undergraduate medical college, and I came across ENG is a must in every college which is having an undergraduate training. ENG is a specialized area. How many of us understand ENT, ENG? Let me ask you, there are so many ENT surgeons over here. How many have actually done, seen, analyzed an ENG? I will not ask it because it's going to open a Pandora's box. But we need to rationalize what we need to do. I teach my undergraduate students radical neck dissection. I teach my undergraduates so many other complicated things. Do I expect my undergraduate students to do that? No. So basically, I must categorize my things into must know, good to know, and that is when I'm going to change it. And this is where the National Medical Commission came into the picture and decided to bring about certain changes. But what happened? All of us have appeared in our MS examination over a period of time. We have very senior examiners over here. Let me ask Dr. Pasi, Dr. Sadeva over here. Sir, when we are taking an examination, how many times have we directly started asking the student about the problem which is there? How many times have we not seen the patient before we start asking? How many times have we asked him so many questions which may not be relevant? I think over a period of time, if we collect the wisdom of everybody, maybe we'll have a fairly good amount of, am I right, Dr. Pasi?
Yeah.
Why it happens is because my flight reaches at 10 o'clock, the exam starts at 9 o'clock, I reach the examination center by 11:30, by that time history has been taken, so I have not seen the student taking the history. I have not seen what he has asked, I have not seen what he has done. He comes into the room and I start asking, what were your findings, sir, cholesteatoma, sir, there's a perforation over there, etc., whatever he may say. Did I examine it? No, I did not. So the question was, my whole viva goes on to a hypothetical situation. Did I need to have an examination? I do not know whether the senior resident or the faculty member, junior faculty member in the department has told him what the findings were. So this came around when we thought that we need to change our examination pattern from the conventional one to the competency-based. Now, how many of you have heard CBME curriculum? Can you raise your hands? What is a CBME curriculum? None of the residents have raised their hands. Okay, fine. There's one lady over, two ladies over there. What does CBME stand for? You said curriculum first. Okay, no problems. Competency-based medical education, perfectly fine. So the word important over here is competency-based. In the past, was I ever looking at my examination from competency-based? Did I evaluate the competencies in the individual? You know, it's very nice to say, let us say at the undergraduate level, show me the knee jerk. And the chap takes a hammer, cut on the knee, patella got fractured, knee moves, and he says, yes, knee moved, therefore knee jerk is present. The question is, did I do the gymnastics maneuver? Did I do it correctly? Did I hold the knee correctly? The foot correctly? Did I tap it correctly? So all these things came across, and therefore, the system changed from a conventional one into today's what is termed as the competency-based system. So, is our system competency-based currently? No. Is our current medical education fit for the millennium? I don't know. Medical education tended to remain within the national boundaries. I did not have money to go abroad. I did not even have money to go to Chennai to see Mohan operating over there. But today, the ways and means are there. COVID has taught us a lot. COVID taught us to go from here to the US and UK in one day and see the surgeries which were being done over there. That, again, is the next ethical question that comes is whether live surgeries are good or bad. That's something I think, again, needs to be answered. Medical education earlier tended to remain within boundaries. Today, it has exploded beyond the boundaries. Education has exploded beyond the boundaries today. We had ENT as one subject. Then it became I and ENT. Then ENT became ENT, head and neck, FES. So many associations came. We had one AOI. Today we have probably more than 50 associations. Why they are there? Because the proliferation of the expansion of services is considered in the subject. But then I have another question. Is it expansion of the subject or is it disintegration of the subject? That again needs to be seen. I am doing only endoscopic sinus surgery, but I am basically an ENT surgeon again. So am I competent enough to see the other things? That needs to be discussed. So what are the problems? Non-uniform medical education delivery, curriculum, evaluation, standards, clinical material training. Given a choice, if I ask a patient, would you like to be operated by Mohan Kameshwaran or would you like to be operated by Achal Gulati? Instant answer will come Mohan Kameshwaran. Why? Because he is good. Achal Gulati is from which medical college? I don't even know that. So the question that comes is, why is there such a big discrepancy in our training, evaluation, and our exposure areas? Because India is a huge, diverse country. More than 700 medical colleges. Different socio-economic, socio-cultural, so many other ethos comes across. Private colleges, government colleges, institutes of national importance. The level over there changes and differs with the entire thing. So my standardization of medical education, whether it is undergraduate or postgraduate, has not been there as was expected and as should have been expected. Today, whenever there is a question in the parliament, the first thing that comes is two categories: All India Institute of Medical Sciences and other colleges. Then it comes other good colleges and other bad colleges. Then it comes private colleges, government colleges. Then it comes private good colleges, private bad colleges. Why should this be there? At the end of the day, we are producing a doctor who is going to treat your and my kids. And therefore, the education level should be the same. This is where the National Board had brought into the picture the objective structured clinical examination, when all over the country, same day, same exam was conducted, same clinical cases, same questions were asked, and it became a competency based because there were 10 examiners and not 4 examiners. There were observer examiners and non-observer examiners. So it came out into a observational based, it came out into competency based. So that is where the change started somewhere in 1999. And today, I think ENT has one subject which has taken the lead role in OSCE, where 38 objective structured clinical examinations have been performed without a single court case coming into the whole picture. Short staffing. Now that again is a thing. I don't have faculty members. I mean, I think Dr. Pasi would agree with me. We have a severe dearth of faculty members across the country. And therefore, am I being able to deliver? Why can't I share faculty members? Again, is a question which comes across. Then skewed access to healthcare. 90% of my physicians and surgeons are concentrated in 10% of my country, in big cities. And 10% of my doctors are spread over 90% of my cities, of my country. So I have a skewed distribution over there. So at the end of the day, I come across that we know the problems, but have we really understood our problems? Have we tried to solve the problems? No, we have neither understood them, nor we have solved them. What were the problems? Can I have the sound, please? This song, let me ask my go-to person, Dr. Pasi, कौन सा गाना है? अजीब दास्तां है, कहाँ शुरू कहाँ खत्म, मंजिलें हैं कौन सी, न तुम समझ सके न हम. This is what medical education is all about. Where does it start? Where does it end? I don't know where does it start, where does it end. What is its end? I do not know. Have I understood it? No. Have you understood it? No. Yet we keep on talking about it. Yes, because I am an expert to talk about it. So, what do our institutions do today? Bring in a monkey and send out that expert person. Does it do that? I don't know. Or does it take in an expert and bring out a monkey? Does it do that? Maybe yes. Or does it take in a monkey and brings out a robo? Or does it take in a monkey, manufactures a beautiful doctor, but because the system is such, he becomes into a sheep and finishes over there. There are 4 scenarios of education in our country, and this is how things work. You know, there's a school in Delhi Public School, which has an open offer. Anybody who has 95% and above marks in 10th standard will get admission directly in DPS. And then DPS says, 95% of my students have got more than 90%. Are you already got a person who was such an educated person, such a good person? What have you done? You give me a student who is a 40% or 30%, and I bring him up to 70%, I get more credit than probably that credit over there. So we need to decide, what do we want? Today, the third picture over there, bringing out robos, is a very practical situation. We stop thinking our clinical skills have become fossilized because we don't have competency-based system and we do not evaluate our competencies. So assessment drives learning. Why? Students wish academic success. Academic success is defined by examinations. Students will therefore do anything to maximize their chances of success. Whatever may happen, चाहे मैं fixing करूं, NEET की fixing करूं, paper I spent 30 lakhs, 60 lakhs for a paper, but it is a examination based, therefore I must be successful, and therefore I will go to any lengths in getting the result, and this is the problem of our country. So introduction to implementation, what happened? From Medical Council of India to the Board of Governors, to back to the Medical Council of India, again to the Board of Governors, and now to the National Medical Commission. This is how our regulatory body has progressed over a period of time. And now, because of the involvement of the universities, institutions, faculties, residents, and all the people who are the stakeholders over there are participating in the system. Therefore, it becomes into a historical reform what the National Medical Commission is bringing out. And that reform appears to be a reformative in all aspects. Transform and reform. Two words. Transform verb, change completely the appearance or character of something or someone, especially so that a person or a thing is improved. When I was long time back, I was weighing 68 kg. Today I weigh 110 kgs. I have transformed myself from a fit person to an unfit person. Or reform. Then my 110 kgs became again back to 70 kgs. So I've reformed myself to a better situation. So whether I need transformation or I need reformation, both of them actually go hand in hand. But today, reformation and transformation has become a run of the mill. I just play with the words and try to alter my curriculum and syllabus so that I bring about, which looks like a better thing, but at the end of the day, again remains the same. So essential programs in teaching, if I look at it, skills, scientific foundations, professional values, population, clinical training, information, communication skills. These things are the ones which have been introduced in the new model, which is known as the ATCOM model. Any idea what the ATCOM model is? Any teacher who is willing to hazard a guess of what is ATCOM? Yes, ma'am. So attitude, ethics, and communication skills, which are very important. And this is why it has been brought, the ATCOM model. Every teacher and every resident must go through the ATCOM model so that he knows what is my attitude, what is my ethics, and what is the principle of communication skills. Today, half the problems in medicine, in doctors, in public dealing end up in communication skills and attitudes and ethics. So this is why it has been made mandatory that every teacher must undergo an ethics course and a course on ATCOM definitely. Communication skills is something which needs to be learned by everybody, how to deal with it. So what we need, Mona Lisa is there, but whether I dress Mona Lisa in a Rajasthani dress or a Bengali dress or a Lucknowi dress, Mona Lisa will still remain Mona Lisa. The external appearances I need to modify so that the emphasis is brought into retaining the original beauty while transforming and reforming the mandated beauties which come across. So system has to be made to think globally but act locally. So where do I train? Today I have a lot of patients in India. But do I actually have in future? Because even getting a cadaver today is a big problem. I think all those who are conducting courses will realize how difficult it is to get a temporal bone or to get a cadaver. I remember 1991, I went to Patna, and me and Dr. Devashi Tandon were there, and we managed to get 10 temporal bones by paying 10 rupees each to a domo of the anatomy department. And at the airport, we got caught carrying bones. That time, Anand Margis was very popular, so they caught us over there. You are traveling with human organs, and therefore, you should be arrested. It was only when we gave our ID and all, they left us. But having said that, today, getting a cadaver, getting temporal bones is becoming more difficult by the day. Dr. Pasi is the best example of how he managed to get. Dr. Pasi, how many alcohol bottles we had to give to the mortuary over there at the civil hospital to get the bones?
Can't divulge here.
So that's how difficult it is becoming. The same way, patients are also becoming difficult because they are more aware of their rights, and this is where the problem comes in. So whether we need simulators, that is important, and the National Medical Commission has said that every medical college must have a skill lab and a simulator lab so that we can train over there. So the anatomy, you see the anatomist over there, we don't require a cadaver. It is a 3D, 4D, 5D, 6D thing. You just keep on swiping. You can get every layer of whatever you want to do. You can correlate with a CT scan, MRI. It's there in that same system itself, so you can learn to correlate. This is where when we learned with our cadaver, however, having said that, again, the haptic use which is there is lost today because the same way, just like the human touch in medical education, the human touch in clinical management has been lost. The same way, the human touch in medical education is also being lost. But we have so many simulators. We have so many good simulators. We have birthing simulators. We have the laparoscopic trainers. We have otolaryngological trainers. We have the humanoid man. Now over here, it's a thing which costs 4 crores or 5 crores, but then it can train me for anything. I give an option over there, okay, fine, inject soda bicarb over there. Suddenly the pH whole system goes haywire and the patient starts fluttering. He has an MI, patient has died. So it is a hands-on training. It can be used for evaluation. It can be used for training. And this is why a skill lab has been made mandatory by the National Medical Commission to go ahead. I'm going to share a picture which is a secret picture with everybody. All of us think that there is no Big Brother watching. This is the online CCTV monitoring center at the National Medical Commission. There are 300 monitors over there which is monitoring every medical college day in and day out, 24/7. You see over there, first picture shows the examination being done. Lectures are being conducted. I say lectures are conducted, I have a full record how many people attended the lecture, how many faculty members gave the lecture. No student, no faculty. So this is actually what is there, that it is being monitored and everything is live over there, which is continuously monitoring. I'm showing you a picture which is there in the NMC nerve center, which is there. So real versus the unreal, whether haptic or cadavers or whether simulators or models, are they really good? एक मूवी आई थी ओम शांति होम, एक चुटकी भर सिंदूर की कीमत तुम क्या जानो. सो इफ आई मॉडिफाई इट, एक अदद कैडेवर की कीमत तुम क्या जानो मोहन बाबू. When I was doing anatomy, I hated anatomy in first MBBS. I bunked my classes. I never got more than 4 out of 10 in any stage viva. And that 4 also I got because I had cut hair, shave, clean clothes, neat apron. Rest of it was 0. When I was doing my MS ENT, I wanted to learn anatomy. Then nobody was willing to teach me anatomy because they said, when we taught you, why didn't you learn at that time? Get out. So that is why I thought, let me hate anatomists by the bottom of my heart. But remember, they play a crucial role in our development. So cadaveric labs, models, workshops, these things are which are very important today, and every medical college is supposed to have a temporal bone dissection lab, which is mandatory as far as the NMC conditions are concerned, if you want to start a postgraduate course. Real is the best, no option. Nearest to the real is the second best. Now, you know, there are simulators. Simulators are there, simulators are good. But do you know, pilots also have simulators? But the worst pilots on the practical things are the ones who are simulator trainers, because they have no fear of death. They know I'm sitting in a simulator, whether I crash my plane, whatever I do, I'm going to come out alive. So they have no fear of death, and therefore they are bad pilots. Whereas a pilot who's training in the cockpit knows that if he crashes, along with the 300 people behind, he also is going to go. The same way, that is why the pilots have a zero learning curve. But in medicine, I do not have a zero learning curve. Whenever I create a complex, it's a new procedure I'm doing, therefore there are certain risks involved, and therefore the patient died. No, I still have no right to have a learning curve over there. I agree. Again, what I was taught in my MS, I do totally different things today. But then I need to be proficient over there, and that is where a good clinical training comes into the picture. So again, एक कैडेवर की, what is the कीमत of 8 कैडेवर? कितनों को पढ़ाया, कितनों को फेल किया एक अदद कैडेवर ने. लेकिन एक सर्जन के दिल से पूछो, कितनों की सर्जरियां ठीक कराई हैं एक अदद कैडेवर ने, और कितने करवाएंगे एक अदद कैडेवर. One cadaver is so important. It teaches you surgery. It teaches you so many things. ये अपने दिल से पूछो कि एक अदद कैडेवर की कीमत तुम क्या जानो सब लोग. So let's not forget the past while walking into the future. What is my future? Hi-fi simulators, technology versus touch, IT proliferation, benefits of artificial intelligence. Today, AI, so many people say artificial intelligence is going to replace doctors. No way, no way. What is artificial intelligence? Today, I would refrain myself from using the term artificial intelligence. It should be augmented intelligence. So when I look at augmented intelligence, is it going to replace me? No, because the person who's feeding it into the computer is a human hand. So a computer, the artificial intelligence will never replace a doctor. Having said that, any doctor who does not embrace artificial intelligence is definitely going to be replaced over a period of time. So you have to be up to date in your IT professionals. How many of us were using the video conferencing before the COVID? Now everybody is talking about only video conferencing. So everybody has become so adept at computer handling that it has changed the entire picture. So machines, computers, the machine learning phenomena, so many algorithms have been formed. It helps me to diagnose X-ray chest, simple thing like X-ray chest, which everybody, pulmonary cox. But today when you see so many hundreds of thousands of X-ray chest reports have gone into creating that algorithm, that today the radiologist is probably a notch down than the diagnosis of what the algorithm has made. Machine learning procedures, collaboration between medical and technical institutions. This is why the NMC has introduced the MD PhD program. You continue from your MBBS doctor, continue till the PhD, and therefore the research technology comes forward. So New Vistas has opened virtual classes, virtual exams, virtual diagnosis, virtual clinical learning. Unfortunately, we have become virtual doctors by not treating the patients. So teaching methods need to be dynamic. Teachers of today and tomorrow need to be dynamic. We need to train the trainee. We keep on talking about train the trainee, train the resident, train that. My question is my trainer trained for that? No, my trainer has to be trained before I can train the trainee, and that is which is very important. So this also becomes a learning lesson for all my teachers across, that I also need to start learning along with my students, because only when I learn properly, I'll be able to teach properly. You know, the computer works on a principle which is called the GIGO principle: garbage in, garbage out. If I feed in garbage to the computer will spew out garbage. So till my teacher is apt at teaching what he is going to teach, he may not be able to produce non-garbage residents, so I must be up to date so that I do not produce the garbage residents. Teach what needs to be taught, what the student and the society needs. Why do I need to know that which is the, somebody asked me, what is the syndrome which has all 12 cranial nerves which are involved? Garson syndrome is there, but what the health practical utility is there? Does it make a difference? The only thing I need over there is, what is the practical utility? So I need to know, can all 12 cranial nerves be there? Yes, all 12 cranial nerves can be there. Whether it is known as Garson syndrome or Achal Gulati syndrome, it takes two hoots. So we need to be aware of the applied aspect of the whole thing. That is where, if you go back, when we are learning the various anatomical books, the surgical anatomy, the applied anatomy is something which we need to focus upon. You know, cricket based on one principle. If the ball is coming on the leg side, you just glance it to the leg side, it will go to the fore. Problem is, if it is coming on the leg side and I try to play it on the offside, the only way the ball is going to fall is on my wicket. So I'll get a hit wicket out. So I need to learn what balls to glance and what balls to play defensively so that I don't get out over there. So I need to harness my technical knowledge and make the best of it. Why reforms are needed? Reforms are needed because I need to produce a good specialist, a good researcher, a good teacher, good healthcare delivery, good communicator, a good human being, empathizer, a good ethically practicing physician, a good up-to-date, tech-savvy, compassionate and responsible doctors. Am I doing that? No, I'm not doing that. I don't deny we were good. You know, 37% of the healthcare professionals, healthcare delivery system in the US is done by the doctors of Indian subcontinental region. That is India, Pakistan, Bangladesh, Sri Lanka. 37% in December, if you go, 37% of the doctors over there are of the Indian subcontinent. But the question is why? Because we were good. I don't deny that, but we need to be better over here. Why are Indians much better on international forum? It's not that Japanese, Koreans, Chinese are bad in their subject. They are very good in their subject. Their problem is they cannot deliver the goods at public conferences. And that is where the Indians take an advantage. An Indian is supposed to be the first best Englishman, followed by the English person. So we want to be better, and therefore we need to create the best, and that is what our Honorable Prime Minister says: make by India, make in India, make by India, make for the world. So this is where we need to come across. So we need to go beyond the traditional lectures, beyond creating an environment where the students can actively participate in the class. What happened in 1960? If my marks were bad, the parents used to shout at me, "You are so poor." And today what happens? If the marks are bad, the parents go and shout at the teacher. That's the only thing. Shouting is there. The only thing is, from me, the focus is shifted onto the teacher. So what it says is that a teacher needs to be more up to date than the student which is there. So who cares about the assessments? Students, teachers, institutions, person, patient, healthcare system, and regulatory bodies. All of them are the stakeholders when I look at the assessment process. So who should be assessed? What should be assessed? Knowledge, skill, and attitude. These three things must be assessed in any examination. What happens today? We have this elephant. Paper setter is different, paper evaluator is different, examiner is different, thesis is different, students are different. So it becomes like six blind men in the elephant. Nobody knows actually what the elephant looks like, yet everybody talks about the elephant. So essay type question. You know, in my first MBBS, we had physiology and biochemistry as one paper. Paper 1, paper 2, biochemistry was 30 marks, 70 marks for physiology. Biochemistry I hated. So I just did three things in biochemistry: vitamin C, I did glucose metabolism, and some vitamin, something else I did. And that day I proved God exists on earth. We had to do only 2 questions, and out of them, glucose metabolism and vitamin C came. Therefore, I got a distinction over there. But had they not come, I would have been sitting somewhere in some market over there selling clothes or something of that sort. So I need to improve my own self. What happened in the past? All my entire careers, this thing was focused on one question paper of 3 hours. I used to pass or fail. And I was sitting scared over there, what happens? And today, I have multitudes of things at different levels when I'm being evaluated. If I have 10 examiners, even if I muck up with one, I have 9 others to make up for. I muck up 2, I have still 8 others to make up for. So the principle of applying across reforms is to process of evaluation should judge your assessment, critical approach, judgment process, problem-solving ability. How many of us take more than 5 minutes to assess whether the student needs to pass or not? Mohan? In a viva of 5 minutes, if I can quote that student who came, asked him 1 question, 2 questions, 3 questions, 7 questions, everything khat, he started replying. So we didn't have any more questions to ask. So then Mohan started asking, when are you going back? Where is your flight? He was so good. But at the end of the day, because I could not prove that he is supremacy to me, so I asked him a question which had no answer. So that I proved my supremacy. I did not know the answer, Mohan also did not know the answer. But then we asked because somewhere or the other student had to say, I did not know. Wrong approach of the examiner. So now what are the things which have changed for every postgraduate? My request is to please focus on these. All broad specialty and super specialty will do a thesis related research and will write a thesis. No leeway on that, you must write a thesis. Today, a thesis has to be submitted 3 months before now to the university from the college, and it will be evaluated at the time of the examination itself, and there will be 20 marks reserved for the thesis evaluation, which is not there in the past. Earlier, thesis accepted, not accepted, it didn't make a difference. Today, we have 5% of my marks, because all MS will be now marking pattern, and 5% of my marks, that is 20 marks, will be reserved for thesis evaluation. Every student must create a logbook, e-logbook, and maintain it regularly. Earlier, what was happening was, at the end of the year, the resident used to come to me with a logbook, sir, please sign, and cut, right from just sign it across. But today, it has to be maintained, and every monthly report has to be submitted. So it has to be done weekly, updated of the e-logbook must be done, it is mandatory. And the NMC would ask for the uploading of the logbook randomly for all colleges. Then a postgraduate student will essentially be required to participate in teaching and training programs of undergraduates. All of us get teaching experience certificate. The eligibility for joining as an assistant professor is 1 year of senior residency. That is where the teaching learning experience happens, and therefore I get exposed to that. Every postgraduate student, whether in a broad specialty or a super specialty, must do either one of these: a poster presentation, a podium presentation, or one research publication. One of these 3 things is mandatory before you can be permitted, and it is the responsibility of the university with the proof to be submitted at the time of the registration. If it has not been done, the degree will not be registered at the NMC. So every student must have one of these 3 things before he can appear in his MS examination. Course in research methodology. You know, what is research? When I was getting my degree, our PGI director said, research is actually researching what has been searched many times before in our country. Not a bad idea, good research, bad research, negative research, positive research. But unfortunately, today research is all based upon copy-paste. So the research methodology course which is there, it's an online course which must be done, or it is conducted by the academic cell of the college. It must be done by every resident before he is permitted to appear. And all these courses should be done in either the first year or the second year. Student is expected to complete this course in the first year. The online certificate generated will be an essential part of uploading while you are doing your registration. And that certificate, once you pass that course, the medical education unit of the college has to upload the list of the students who have done onto the NMC website, so that when they are registering it, they are sure that you have done the research methodology course. Then comes online research methodology applicable to all postgraduate PGs, not only PGs, but to all teachers also. So all teachers also have to be a part of this research methodology and ethics course which is there. And this is which needs to be done. A course in cardiac life support, ACLS course, must be done by every resident. All this also must be done in the first year, and the certificate of this would be given by the MEU of the college, which is governed, which is monitored directly by the NMC education cell, and therefore every student who has done it, his name is already there in the NMC website. It is on public display, and therefore while time of registration, you have to quote that number while you are putting it over there that you have done this advanced life support system course. Then district residency program, a program DRP which should be done in the 4th, 5th and 6th semester. It's a 3-month posting in a district hospital. 80% attendance is mandatory for this course, and this course will be certified by the local medical officer and the report submitted. And within 1 week of you having completed the successful course, the thing has to be informed, the NMC has to be informed that this person has done his course so that it can be uploaded on that website. So the main objective of DRP is to see that you are on the ground level, how the public health programs, the national programs are implemented, whether you are capable of treating a patient in an emergency in the rural setting without the backup. I mean, so many times we are in an aircraft and suddenly one bell goes up, any doctor on board, please come and have a look. At that time, it's a scary thing whether you should really claim to be a doctor or not, because if they ask you to put on the oxygen cylinder, maybe I don't even know how to put on the oxygen cylinder, or if I have to give the shock over there, can I use that or not? All of them are very debatable things. So this is something which we are going to learn. And while you are on the DRP, during the DRP, you must be in contact with your department, and all online classes must be attended over there. Your seminars, journal clubs would be attended while you are on DRP. Examinations. Now the examination would be conducted. There'll be a examination. Fortunately, the rule which is applicable to the undergraduates is not applicable to the postgraduates at present. The undergraduate rule states that if I'm short of attendance, I cannot appear in my annual examination. I cannot even appear in my supplementary examination. If I am short of attendance in my annual examination, I will appear only in the next batch. That means I lose a year. Only those who have failed in their annual examination will be appearing in the supplementary examination. Or if I have been detained because of the lack of internal assessment marks, only then I can go for my supplementary examination. But attendance, you have to waste a year. Fortunately, that is not there for our postgraduates. Therefore, we can still manage to have, but 80% attendance is mandatory for all postgraduates. Now, what the NMC has done over here is a big leeway that I have approximately 1,050 working days in 3 years, 1,050 days in 3 years. And out of that, about 156 days are Sundays, weekly offs, and 20 leaves, and therefore it works out to approximately 780 working days. So if I take 850, 80% of that is 750, so I need to attend my, at least for a 750 days. If I do not have that 750 days, I get a repeat posting over there. So attendance has again attained a slight significance over here, though there are a lot of leeways over there as far as attendance is concerned. The MD, MS, MCH...
Dr. Gulati, some time...
Yes, I'll just finish in just give me 3 minutes more. Yeah. So, because this is for the residents actually, that's why I just took some time. So, next thing that comes is, when we talk about the MD, MS examination, there will be 4 papers, the same tradition continues, but earlier it was you had to get 50% in all the papers. Today you need to get only 40% in any paper to be eligible, but sum total of all the papers must be crossing the 50%. So, the clinical, practical, viva voce, the thesis will have a separate topic on viva voce, which becomes important. The marking of the papers will be like this: 4 papers, 100 marks each, theory for 400, minimum passing is 200 or 400, but 40% in each paper is mandatory. Practical, viva voce 300, and viva voce for 100. So minimum passing of 50% is required. Theory, 5% marks for thesis, and no grace marks are permitted. MS, MD examination will be marked. There are no grace marks. So if anything hanky-panky has to be done, it has to be done before the result is written over there. I cannot say that I have 49 marks and then I give 1 grace mark and pass it on the university. No, that is not possible. So after your MS ENT, what all can you do now? This is something which is important for all of you. You are eligible for DM medical genetics. You are eligible for MCH head and neck surgery, you are eligible for MCH plastic and reconstructive surgery, and you are eligible for MCH surgical oncology. So these 4 areas for super specialization are now available, for which I think we owe thanks to Dr. Suresh Sharma for insisting that these three things, apart from head and neck was earlier permitted, the other 3 things have been added thanks to Dr. Suresh Sharma, who was the chairman of the NMC at that time. So whenever we are talking about reforms, no reforms can be brought in suddenly. It's a subtle change. And you see the Iron Lady on this side, Margaret Thatcher, and you see Marilyn Monroe over there, gradually changing from one thing to the other, but over a period of time, the future will change and make a big difference. Examination reforms for postgraduate, happiness is the end of the examination. Examination should not be a tense body. Examination should be a relaxing thing. I should be able to call the examiner and say, you examine me, something like what this lady is doing. Again, the sound is out. Dr. Pasi, again I come to you. कौन सा गाना?
आइए मेहरबान,
आइए मेहरबान, बैठिए जाने मन, शौक से लीजिए मेरा इम्तिहान. This is what this lady is trying to say. That is what my attitude in an examination should be, as this most beautiful Madhubala says. And this is what, thank you so much for giving this opportunity. My apologies to the chairperson for overshooting my time, but then because the reasons involved, therefore I thought we must get it across. Thank you so much.
Wonderful, Dr. Gulati, as ever. Thanks for sensitizing our postgraduate students about the latest guidelines of the National Medical Commission, competency-based medical education. Thank you very much. There is no time for any queries.
Thank you so much, sir. Since we are actually short of time, I request all the speakers to respect the time limit. And this is time to honor our eminent speaker. Please give a big round of applause, sir. Thank you so much for enlightening us. Becoming teacher is not an easy. We got get it, sir. Now I request our chairpersons to please felicitate our speaker. And may I request the volunteers to please bring the memento of appreciation. I think, sir, you have opened the Pandora box for everyone. That teacher used to be, now everybody thinks that I have presented 2 papers and delivered few talks and I have become a teacher. But teacher is a lifelong process. It takes a lot of stakes to become a good teacher. There was a time when it used to be called that a teacher is like a candle who burns himself to enlighten the life of his or her disciple. Ab Kalyug hai, at least we can't say that teacher burns itself, but at least teacher has to be the mirror in front of which a candle is put, and he can enlighten and divert that light to all his disciples. And I request Dr. Kakkar sir to please felicitate. I once again thank Dr. Achal Gulati. Thank you, sir. Now I request Dr. Kakkar sir to felicitate our chairperson for this speech, for this talk. Dr. O.P. Sachdeva, a revered ex-head of department also of PJMS Rohtak. Thank you so much, sir. Revered teacher. And also Dr. Pasi. Thank you so much, sir. May I request Dr. Sana to please come on the stage for the next session.